welcome to the American Journal of Psychiatry Residence Journal podcast. My name is Dr. Lindsay Lebin, and I am the Deputy Editor and Podcast Editor for the Residence Journal. Our guest for today's show is Dr. Tom Soeprono from the University of Washington. Tom completed his residency in psychiatry and his fellowship in consult-liaison psychiatry at the University of Washington in Seattle. Leadership and education are at the core of his academic interests. One of his primary roles is the Associate Program Director for Psychiatry at the University of Washington Medical Center. Clinically, he has worked on inpatient psychiatry, the Psychiatry Consult-Liaison Service, and is currently the Director of Transplant Psychiatry, as well as a primary care consult psychiatrist in a collaborative care clinic at the University of Washington. So Tom, thanks again for joining us on the podcast. You have a lot of interest, but I'm really hoping to especially focus in today on transplant psychiatry, especially since I think a lot of trainees might not be familiar with it, since it's kind of a niche subspecialty within consult-liaison psychiatry. So to start off, I'm wondering if you can tell us some of the basics about transplant psychiatry.
Yeah, thanks for having me. I really appreciate being invited. So transplant psychiatry is pretty unique in that most psychiatrists aren't going to practice this. I practice this in a outpatient setting in a specialties clinic alongside, my fellow hepatologists, nephrologists, and so forth. And it's a great multidisciplinary setting where we really get to the core of kind of what CL does, both the liaisoning and the integration between psychiatry and mental health and physical health, even though, that kind of dichotomy is kind of false in many ways. So a majority of what we do is we do one-time consultations there, evaluating people to ensure that they're psychologically stable and fit and prepared to go through transplant, which, as you know, is a very difficult process. We evaluate people on a number of different factors and try to work with the team to prepare people to kind of mitigate risks that are associated with transplant because it is such a stressful situation.
Absolutely. I guess I'm also wondering if the types of transplants come with any particular psychiatric issues generally that you have to try to address.
Yeah. Generally speaking, I see patients for liver, lung, and kidney transplants. Obviously, there's also heart transplants and vascular transplants or CVA. But those are a little more rare, the CVA specifically. In each organ, because of the physiology that's related to the organ failure, there's associated psychiatric illness. So as you might imagine, people going through lung transplant tend to suffer from anxiety because of the experience of suffocation. And correlated with liver transplant is a lot of substance use problems. So naturally, we do a lot of substance use evaluations and treatment of substance use in the liver folk. And then because of the long-term challenges associated with being on dialysis and how it really pulls you out of your normal function in life, people tend to get pretty demoralized and sometimes depressed when they have kidney failure. So that's kind of a broad overview and generally speaking, but obviously there's a lot of variation for each individual and it's quite unique for each person.
That makes a lot of sense. I'm wondering if you can tell us a little bit about how an evaluation in transplant psychiatry differs from just a general psychiatric evaluation.
In many ways, it's exactly the same. We don't do anything too different, with the caveat that there are 4 additional components or maybe extra additions. As I talked about related to the liver transplant folks, because substance use is such a prominent feature of their illness often, I really do a much more thorough substance use evaluation, and especially thinking about it in the context of relapse because of how that might relate to adherence of medications and the long-term viability of their transplant. The other 3 components that are unique to transplant are a real thorough evaluation of adherence because of immunosuppression being a necessary component of transplant. Patients need to be very reliable because we don't want somebody to lose their organ because they haven't been appropriately evaluated, and we put in the appropriate factors to ensure that they can maintain long-term adherence to their medication. The next ones are care support and then also a soft capacity evaluation. We want to make sure people are making an informed decision, obviously, but we don't go through the more formal process of capacity evaluation. On the other hand, the care support evaluation is done not just by psychiatry, but primarily by social work, but we usually check in on that because the relationship between the social settings, one's care support, and their psychiatric illness are so closely related.
Mm-hmm. That makes a lot of sense. Do you ever ask about coping mechanisms since transplant is such a stressful process?
Yeah, I think that it varies by organ again. Lung is often one of the more difficult transplants, and people are in the hospital for multiple weeks. And anybody who's been in the hospital for multiple weeks knows that it's really hard to just be there, let alone going through a very strenuous and difficult process that involves maintaining motivation and enduring pain and being in uncomfortable and vulnerable positions. So a thorough evaluation of one's coping strategies, although that's really challenging to do because these people know that they're in the limelight and trying to make it through the transplant evaluation, getting an honest evaluation of those things can be challenging.
You mentioned that one of the things that you do in the transplant evaluation is look at adherence because of the concern about how it could impact transplant outcomes. I'm wondering if you could tell us a little bit broadly about the relationship between psychiatric illness and transplant outcomes.
Yeah, there's a lot of varying literature on this, and it's difficult to kind of summarize in a sentence. But I think if I was being forced to say a sentence, is what you alluded to a certain degree, was that psychiatric illness is a direct result of both a combination of genetic predisposition, but in this setting, specifically a lot of psychosocial stressors and physical stressors as well. And those stressors usually manifest in certain individuals in psychiatric illness that can lead to non-adherence in their immunosuppression medication. Additionally, there are other things that psychiatric illness can lead to. So participation in physical therapy, maintaining sobriety, and participation in other follow-up care related to transplant. All these factors play a huge role. And so I wouldn't say it's specifically the psychiatric illness itself, but more the sequelae of that psychiatric illness. As an example, if somebody's depressed or less likely to take their meds, get out of bed and do the physical activity they need to, and so forth.
So it seems like you do assess a wide range of things in the transplant psychiatry evaluation. With all of that information that you gather, what types of recommendations and interventions do you make in transplant psychiatry to help patients?
Yeah, because this is a CL setting, there's a wide range, and we go anywhere from just seeing them once and kind of stamp of approval, things are good, you don't have to see us ever again, as far as to see them multiple times and at times, provide a regular and frequent psychotherapy. We don't have a huge capacity for that in our setting, but to a certain degree we do that if we think that we can make some quick changes in a few visits. I try to focus primarily on behavioral changes because I see those as one of the more important interventions that we can make that make lifelong changes. We do prescribe medications that can help, but usually that's just symptom management and very short-term in nature. If somebody has a chronic psychiatric illness, we're hoping and the expectation is that they'll have long-term psychiatric follow-up. And that's another thing we try to do is bridge care because sometimes it's just awareness of certain resources and so forth. So it's not unlike other clinical settings. I would say that we have the benefit of having the support of a multidisciplinary team and then a lot of, more financial support given the fact that it's a transplant setting.
So you've mentioned this multidisciplinary team a few different times so far. I'm wondering, where does the psychiatric evaluation fit into the larger context of the overall transplant evaluation process?
It's certainly not the center of it, but I think that we have almost like veto power that at any point if a patient is having a lot of psychiatric difficulties, we can intervene in that way. So in many ways, we're a small piece of the puzzle, but a small piece that can have a large influence.
What other parts of the puzzle are there typically, just generally? Yeah. Who do people have to meet with?
Certainly. So a broad picture of who's participating in the selection committee is the primary physician related to whatever organ. So in the case of lung, it'd be the pulmonologist. On top of that, there's the transplant surgeon. There's the nutritionist who plays a very central role because nutrition is such an important component of healing and then ensuring that they have the reserves necessary to go through the transplant. And then probably our brother or sister specialty social work, who has a lot of overlap but has such a nice different vantage point on psychosocial interventions that they're an imperative part of the transplant process.
Are there any absolute psychiatric contraindications to transplant?
Contraindications to transplant vary from center to center. The absolute contraindications from a psychiatric standpoint are pretty rare because, first of all, the patients get screened before they even get referred to transplant. If a primary care physician doesn't think a patient's going to be able to even get approved for a transplant, they're probably not going to refer them until they tee them up for it. So that being said, the absolute contraindications from a psychiatric standpoint are ongoing substance use, which is usually never an issue, ongoing non-adherence, and untreated or intractable psychiatric illness, which could kind of really be from any realm, but it usually comes from the psychotic realm. If somebody has never really been psychiatrically stable and that instability has led to inadherence, I would consider that an absolute contraindication. On the other hand, if somebody does have chronic psychiatric illness like schizophrenia, but has consistently shown that they can, despite decompensations, maintain their adherence, that's somebody that might still be able to make it through transplant, and we need to talk about that in the selection committee meeting. In terms of relative contraindications, those can be things like personality disorders, care support, and again, substance use kind of lays into that.
Do neurocognitive disorders fall under this domain that you assess?
Yeah, that's a great question. Neurocognitive disorders do at times. I think it really, again, layers on top of what kind of support they have. So somebody who maybe has Down syndrome, we might not restrict that person from a transplant because we don't anticipate that there's going to be a rapid decline in the foreseeable future. And we have to kind of assume to a certain degree that many of these people already have care support that provides in many ways 24/7 support. So in many ways, they can be some of the best candidates.
So it sounds like, with each type of psychiatric illness or condition that you're looking at, there's no blanket position that a transplant psychiatrist would take, like, oh, that person with schizophrenia, they can't get a transplant. It really depends, it sounds like, on the severity of the illness and the support system that they have in place and their general pattern of functioning that they've exhibited thus far.
Absolutely. You hit it on the head. Job security for me and psychiatry in general, much like the rest of psychiatry, if we had a little rule book, unlike the DSM, that we could just follow, certainly our jobs would be a lot easier, but we might not be necessary. But I think
and it would be a lot more boring, too.
That's true.
Yeah.
But I think that that's really the beauty of what we do, because taking each individual on a case-by-case basis makes sure that we do what's right by the patient, and also, given the very limited resource of organ allocation, we're doing right by the donors as well.
Can you tell us some of the ethical considerations and dilemmas that have come up for you in transplant psychiatry?
Yeah, probably the most obvious ethical dilemma is our role as a psychiatrist in this setting, because we're doing both evaluation and advocacy at the same time. And that's a hard line to walk along, because a patient might confide in you very sensitive information that you don't feel necessarily comfortable sharing with the rest of the selection committee meeting, but that also might exclude them from being a really good candidate. So trying to understand what's in the best interest of the patient and what's fair and equitable to the rest of the population is where the ethical considerations really come up. Again, we take these on a case-by-case basis. But these ethical considerations are at the heart of what we do, and I think why it's really important that psychiatry be so involved in transplant, because I think we're better suited and equipped to deal with those challenges.
Do you ever feel like patients perceive you as being in a gatekeeper role?
Yeah.
Or do you ever feel like you're in a gatekeeper role yourself?
Yeah, as much as I try to not be in that role, you get pinned that because the whole process of getting on the transplant list is called the transplant selection or evaluation process. So we are put in this gatekeeper role. I try to kind of flip that on its head by explaining to the patients that if you were to be excluded or there were contraindications to transplant, you actually don't want to go through a transplant yourself, because the whole point of going through this selection process is to protect you from the drawbacks and the risks and the real harm that can come from the transplant itself. This is not a benign process. And, I've seen many patients who have maybe tricked their way or maybe not been totally honest about certain components of their history that results in really negative outcomes that I think if they could go back in time, they might have gone about it a different way. Being open and honest certainly can delay your process, but that doesn't mean it necessarily will exclude it. And hopefully, my hope is that it will protect patients from really bad outcomes that otherwise we could avoid.
Yeah, definitely. I'm curious if we could take a little step back here. I think trainees would probably appreciate having an overview of how you came to practice in transplant psychiatry and in your career journey thus far.
Yeah, being a CL psychiatrist, one of the reasons I think that a lot of people go into CL in the first place is because they like the excitement of the hospital. They think of themselves as inpatient docs, and they like the team aspect. And that was certainly me in every aspect. That's where I started out, is on inpatient CL, and I covered some of the inpatient units here or there to help out. But primarily, my focus was on inpatient CL work. So when my chair proposed that I do this transplant work, which was all outpatient at the time, I was pretty skeptical. But if there's one thing I learned in being an attending and being out of training, is that things are very different as an attending as they are when you're a trainee. I didn't especially like inpatient work, but it's actually much more enjoyable as an attending, and things are quite different when you're not in the trainee role. So I took on this job, which is now mostly outpatient, and I've actually really loved it.
What were you most skeptical about in terms of outpatient work?
Yeah, I was worried about being pretty isolated. You're there in your clinic, and especially psychiatric work can be very isolating if it's just you alone and you're amongst a lot of maybe other providers who might not be interested in the same things that you are. But I have to say that's not been the case. I think once you form a long-term relationship with other providers from other specialties, a lot of our work happens on a curbside basis, and I get to utilize many times my liaison skills in the clinic amongst all these other providers more than I would have on the CL service on inpatient, because I'm sitting there kind of waiting for my outpatients to show up, and so we're all kind of in a workroom together. So it's really nice, and I think that in many ways enjoy it more.
It sounds like it's maybe less different from the inpatient team atmosphere than you were expecting.
Certainly, and I think it is different than your typical outpatient psychiatry practice where you might be seeing people from med management case after case. I think it really helps the actual architecture of the clinic, and if there is a provider room where people will actually inhabit, and the way those desks might face each other or face away, or cubicles, and also the culture and atmosphere of the work environment. So I'm blessed to be in a very collegial and friendly atmosphere where maybe I might not be getting as much work done as I would like to in the workroom, but it's worth it.
You're doing the liaisoning.
That's right.
Can you tell us what the most gratifying part about working in transplant psychiatry is?
Well, I don't think this is particular to transplant, but I think the educational component and working with trainees has always been my favorite part of all of my jobs. So I try to take that to every place I go. From a transplant perspective, I would say the multidisciplinary teams and working in these big systems has been really nice. It's rare that in most psychiatric settings that you get to take a patient who's struggling with appetite problems and refer them directly to a colleague that you know and trust and can say, hey, this nutritionist is fantastic. Maybe you can see him and he can help with this aspect on top of prescribing the mirtazapine that's helpful.
Yeah, absolutely. In contrast, what's the most challenging part about working in transplant psychiatry?
Well, you get pegged into very challenging positions, not just by colleagues, but by patients as well. I think, as in all of psychiatry, there's a natural bias amongst certain individuals, and I wouldn't blame this on specific specialties. There's bias, and we all have it to varying degrees. and it becomes very apparent in stressful settings of life and death and transplant. So I think when there's high stakes like that, it makes patients even more sensitive and vulnerable. So that's been very challenging, and it's rewarding when there's good outcomes, but there are, as you can imagine, very life and death bad outcomes that occur, and that's hard. People die very, very frequently that we evaluate in transplant.
And how do you personally cope when those bad outcomes happen?
Well, I try to be a good example for my trainees and model behavior, but I have to admit that it's a little bit selfish on my part, because part of that is the decompressing and discussing the challenges that I have and being really transparent. I think the team as a whole is pretty open to talking about how hard it is to see these patients that we invest a lot of time and energy in not do well.
Is there anything that has surprised you about transplant psychiatry that you weren't necessarily expecting when you first started the job?
So the most surprising thing has been the diversity. Coming back to that question you asked me earlier about hesitations in being a transplant psychiatrist, that was my worry. I was worried that I'd see just case after case of organ failure that was really just the same, and I'd get bored. I'm very prone to seeing patterns in behavior and patient populations, and then once I feel like I figured it out, I can kind of get bored pretty easily. But that wasn't the case with transplant. I've seen some of my most difficult cases that I've ever seen all in the transplant setting. Just such a wide range of diverse situations. I think because the psychosocial situations are brought to the forefront because of the stress level, and then also the dynamics between the patients and the other providers. We invest a lot in transplant into these patients, and we see them very regularly. So there's pretty deep relationships, and as a result, they can be very gratifying and rewarding, and it creates a very prime situation for interesting cases.
So probably most trainees won't end up practicing in transplant psychiatry, but what do you think trainees should know about this field and transplant patients in general, regardless of what field they end up practicing in?
Yeah, I realize that most of the trainees that come and work with me aren't going to be transplant psychiatrists. There's very few positions and funding for that, and ultimately there's a lot of work that needs to be done in other places as well. That being said, I think every trainee can learn a lot from working in a transplant setting, and I'd really encourage all trainees to, if they have that opportunity to work in the transplant setting, because you get this rare opportunity where you have this giant carrot of transplant where patients are extremely motivated, life and death kind of situation, to get on the transplant list. So you can require things like behavioral changes that you can't often see really the full timeline of how behavioral interventions manifest in a regular psychiatric setting. So I think from the perspective of developing behavioral skills and strategies to improve patient care, which is, I think, one of the best ways to improve patient outcomes, can be done in a transplant setting instead of kind of defaulting to the easy and kind of straightforward process of prescribing a med, seeing how it panned out, and just making med change after med change. I think it's really a prime situation for behavioral changes and to see how those work. Another situation would be providing patient education. Patients come into the transplant setting quite naive about the process, as you'd imagine they'd be. Nobody imagines themselves, 10, 20 years from now having to get a transplant. And it's a very intensive process with a lot of nuance and specific situations that you wouldn't imagine or anticipate. So we get to provide a lot of patient education, and I think developing those skills and communication skills is another unique skill set that you can learn from transplant psychiatry.
Yeah, it definitely seems like there are a lot of really practical things that you can take away from a transplant experience into whatever practice setting you end up in.
That's my hope. I would say it's more like other psychiatric outpatient settings than it is different. Although I think that the uniqueness makes it especially interesting.
Yeah, I mean, it seems like a really nice combination of being able to do some management for people, but also really employing a lot of psychotherapy skills at the same time. So it seems like a nice combination of those two skill sets that you get to practice as a psychiatrist.
Certainly, and I would say that it probably varies quite widely from transplant center to transplant center, and depending on the amount of patients that you see and how much FTE is allocated there, because there could be very little FTE allocated, in which case they might not allow you to see patients as frequently or in as much continuity. And each, setting, it's not good or bad per se, but it comes with its strengths and weaknesses in every scenario.
Absolutely. Well, Tom, I really appreciate you taking the time to talk with us a little bit about transplant psychiatry and give us some information about what practice is like in this subspecialty. Thanks for joining us.
It is my pleasure. Thank you for inviting me.